colleagues and friends, I would like to welcome all dear colleagues here in this very interesting session. I'm really very happy. I'm very glad to have all these eminent speakers and friends and colleagues and brothers from everywhere. And we will start our session with the most pioneer speakers worldwide. And my brother, my friends, my teacher, what can I say more than that? Can you show me his, please, to introduce him? Sorry, before that, I have to also, I have Dr. Patricio Lorenzo as a co-moderator, and he's a consultant ophthalmologist, Quiron Salt Cataract this center in Dubai, Cataract and Laser Surgery Hospital in Dubai. First speaker will be Dr. Majdi Musa, and he's a professor of ophthalmology, VR consultant, director of the Medical Retina, Faculty of Medicine University, and his topic, it will be mystery case presentation. Please, Dr. Majdi, let's enjoy what you are going to present us.
I hope you will. Thank you, Muhammad, for the introduction. It is not that total mystery, but this I will open the discussion with the panelists and the moderators because it's a very interesting case. It's a pigmented fovea lesion with serous macular detachment. Again, it's not working sometimes. Yes, now it's working. So she is a female patient, 27 years old, and she had left recent diminution of vision. The visual acuity in the right eye was 6/6 and the left eye is 660. And she had history of the same condition 1 year ago, and I was lucky because she already had her OCT, everything, fluorescein, and I picked this up and I scanned everything and I will show you. She had no systemic illness, and this is her fundus picture. Sounds like a foveal RPE hyperplasia, pigmented fovea, surrounded by mottling of the retinal pigment epithelium, and there is bullous-like elevation superior to the fovea, and atrophic lesions beyond the inferior arcades where I am pointing now. So these are two peculiar lesions, bullous or serous detachment superior to the fovea, and pigmented lesion inferiorly beyond the arcades. So I did fluorescein angiography for her. She had hypofluorescent foveal pigmented lesion, as we should see here, and we already guessed that from the color fundus picture, surrounded by early transmitted fluorescence, which denotes RPE atrophy. And there are multiple drusen-like spots at the edge of this lesion, which are stained in the late phases. And she had late pooling of the dye under the serous macular detachment, seen superior to the fovea. So this is the picture. Otherwise, there's nothing else in the right eye. And this is a magnified picture showing the serous detachment here and the pigmented lesion and drusen-like spots around the fovea. This is the OCT she had, and she was diagnosed as a CMV, and she was already diagnosed as a CMV 1 year ago. And this is the recent OCT she had. She brought with her, and she was referred to me. So I did fluorescein angiography to make sure that she had fluid. Yes, she had fluid. She had pigmented lesion, and this is her OCT 1 year ago before she had double injections, double anti-VEGF. So let me stop here and chat with the panelists and with the moderators. What do you think this lesion is? Is it really a CMV? Is it something else? Are we missing something in this patient? Anybody wants to make a comment?
Yeah, there is an OCTA, Dr. Majdi, before that?
No, not now. I will do if you ask for OCTA. But let's speak about what is going on in this. Let me show you the.
Who is going to talk first? Dr.
Fluorescein. Anybody wants to comment? Not first. Anybody wants to comment because we are going to discuss it. Like I was brainstorming with myself.
I wanted to ask.
Please.
Okay.
Was there any history of laser, doctor?
To ask.
Who's asking me?
Dr. Madap is asking you.
No, there was no history. No laser point. She's an adult and she's well educated. She doesn't have any history of that.
Professor Musa, just two questions.
Yes.
Is she myopic? Does she have an ultrasound scan? And does she have an ICG?
No, unfortunately, she's not. She looks at, tigroid fundus, but she's not myopic. There's no refraction, only minus half cylinder.
Okay. And
So-
has she had an ultrasound or an ICG?
No.
Because there looks to be some kind of choroidal lesion there that's giving a kind of a dome shape convexity to the central retina, sort of central macula there.
This is her OCT and the recent one, and this is the old one. Dr. Patricia, you wanted to ask anything?
I wanted to ask you, is this patient had any vitreous cells or any systemic condition?
No, no.
Yeah,
She already had
Alfredo?
investigations, but investigations for what? She was diagnosed as CNV and injected twice 1 year ago.
It doesn't mean they were right.
Right, you are right. You are right. Let me show you that.
I see this choroid seems to be very, very thin. Like if there were something, there was.
Here's the sweat source. Give me your comment on the sweat source, Dr. Patricio. Look at the sweat source. It's marvelous here to show what is going on, which we didn't see with the regular spectral domain OCT.
I think that
What do
this
you think?
patient has something just probably even outside of the eye wall.
Yes.
So there is a choroidal lesion which is pressing on subfoveal
right.
choroidal lesion, which is causing a dome-shaped elevation of the macula.
Right, with serous detachment.
With serous detachment.
Yes, because when I looked at her,
You have
it
an
sounds like
EDI.
I have at what?
EDI. I mean, you can probably see the entire choroid, and
yes, yes, but this is better than EDI. It's like a sweat source. But let me. When I looked at this, I said, yes, it's a choroidal lesion doing this, because this was, I mean, this hyperreflective lesion, which is seen in the color photo like pigmentary hyperplasia, this was misleading. The main lesion is in the choroid, as everybody noticed, it is in the choroid, but this is something like RP detachment with underlying migrated retinal pigment epithelial cells. Dr. Al-Amri, do you still need the OCTA?
Yes, why not? Just to see. There is,
Okay.
I mean, just.
So this is what I thought. So I said to myself, what is next? I wanted to confirm the presence of CNV or to exclude it because there is fluid there, but we don't know why the fluid is there. So this is the OCTA, nothing. There is no CNV.
So here I think we can go to ultrasound or CT.
For what?
If there is any mass behind.
There is a mass lesion. There is a mass lesion down there. So I mean, what ultrasound will give us more than the OCT and the fluorescein?
Have you got an ICG done?
No, we don't have ICG. We don't have ICG in Egypt.
Would the CT orbit be beneficial as well? In this case,
I'm sorry?
just in case there's a CT orbit to exclude a posterior lesion, compressing.
Like what?
So I've diagnosed a sphenoid meningioma with a very similar.
No, but I mean, fluorescein will be diagnostic for him.
No, sorry, a
meningioma.
So this patient had a sphenoid meningioma.
You mean sphenoidal ridge or whatever the meningioma is?
And he was
so
giving a
why we are going to the extreme? Why we are going to the extreme?
Why? Can we see the next?
As we are some element of scleral scleritis, posterior scleritis, and pushing the choroid
and she did. No, but again, let me show you the fluorescein. The fluorescein is conclusive. It is not a scleritis. There is no nothing in the fluorescein, and the only thing we didn't comment on is this: some drusen-like structures around the foveal hyperpigmentation.
Yeah.
But anyhow, let's cut the story short. Can I do anything for her in this case? I mean, sometimes observation only is quite good enough to know what is going on, right?
Yes,
because the same lesion 1.5 years ago, the same lesion 6 months ago, and the same lesion she presented to me. If this as Dr. Fahd suggested, is a tumor, it will be progressive. If it is scleritis, it will go away. But 1.5 years with this, you have to think of long-standing lesion. Could it be a nevus?
Yes.
It could be. I mean, why we are going to the other side of the hill? It's simply, it could be a nevus with overlying hyperpigmentation and drusen-like deposits over the surface of the nevus, which is very logic. But at this stage, would any of you treat the patient or just follow up?
Follow up.
Okay, I told her we need to follow up, and I gave her, it's a fluid, so I gave her erelunor, like spironolactone. And this is 2 months later. marked regression. Why? I don't know, but probably some of this patient, as the tumor press on the choriocapillaris and cause the fluid under there, I thought, why don't we use like the CSR? So she started to get much better. Minimal fluid, she's improving, and the same lesion, dome-shaped macula with hyperpigmented center, and this is 6 months later, and this is the best corrected visual acuity 618 instead of 660. So the fluid was the thing the patient brought the patient in. She had a nevus. Sometimes the nevus can develop fluid, serous detachment, and we should not hurry to inject this patient as happened 1.5 years ago. And even her doctor called me, why don't you inject her? I said, why to inject her if I don't have a CNV? And this is what I found in the literature. Sometimes PDT of the subretinal fluid from choroidal nevus is helpful, but we don't have PDT in Egypt, thanks God, because I would have tried it, but I shouldn't. And this is selective retina therapy for subretinal fluid associated with choroidal nevus, like micropulse laser. They sometimes say it will act by triggering the retinal pigment epithelium to absorb this fluid. And this is the case where they have nevus with subretinal fluid, and then after the micropulse, she had improved. So my take-home message is choroidal nevus is with overlying. Sometimes you don't find only fluid, it's also RP detachment. This is a case I presented in Dubai 5 years ago, which was like a mystery retina also, where a patient was 70 years old presented with this. We showed it's a CNV, and always look beneath the retina by EDI or sweat source, and observation or PDT, if it's available, can help in absorption of the subretinal fluid. But again, simple thing like spironolactone might do the job, and careful evaluation and meticulous interpretation of different imaging modality can help and can avoid the hazard of intravitreal injection. Thank you so much for your listening.
Thank you very much, Dr. Majdi, for this very nice and excellent case presentation as usual.
Just a quick comment. Yeah, very quick comment. I think it's a very nice case, Dr. Magdi, but I think doing a B-scan also can give us the internal anesthesia to make sure we are adjusted as a nevus, but just to complete the image. I think B-scan will give you also a clue or more advanced that you are not dealing with melanoma or nevus, because the internal activity will show different. So I think yeah, B-scan will be helpful in this case.
But I will answer that. Also, sweat source OCT is very good in delineating the melanoma from the nevus. So it's not markedly shadowing what's underlying. The content of the tissue is not like the melanoma. It is not degrading, so it's not shadowing what's underlying. You can see even in the OCT, the choroid and the underlying sclera. So that's why I didn't suspect it's a nevus. It's a melanoma. And the third thing is the follow-up. During follow-up for 1.5 years, if anything happens, that means the progression of the lesion will be fatal if we miss a melanoma. Thank you.
Yeah, this is very nice. Good for follow-up, because the fluid is, you know, if you have a fluid with nevus, it's you have to keep eyes on that. So
this
is the most
being
important
central nevus like this, and not just one, I think it is always we should always be suspicious of melanoma. I've seen the lesion down, but I thought it's a nevus, but at this age, 27 years old, it's
it sounds like a congenital one. It sounds like the congenital one, and that's what happened. The fluid, when sometimes the decompensation of the RP happens with the time, the fluid is accumulating. But once the fluid is gone, she regained the vision. I told her, she said, this eye was not good since birth, but again, she came because of the fluid. Drop of vision 660 was because of the fluid, I think so.
Okay, thank you very much. I think we can move to the next case, if you don't mind. So sorry, Dr. Ahmed. So the second speaker would be Dr. Madaprao, and he's a consultant ophthalmologist and vitreoretinal surgeon, head of Department of Ophthalmology in Burjeel Hospital, Abu Dhabi. Please, Dr. Madap.
Am I audible?
Yes, please.
And can you see my slides as well?
Yes, please, go ahead.
Yeah, at the outset, I would like to thank Dr. Alamri. Good evening, all. I would like to present a couple of cases. Dr. Alamri, you can always stop me if I overshoot the time. There is nothing mysterious about these cases. I wanted to give the flavor of this pandemic. I'm presenting a few cases of retinal vascular conditions during the pandemic. So here is a 35-year-old male presented to us in the first wave of pandemic COVID during June 2020. He was complaining of sudden loss of vision in the left eye for the last 2-3 days. He was treated during the COVID with IV, dexamethasone for his inflammation in the lungs. So he says, according to him, he developed diabetes in the last 1 month when he was COVID positive. And he became negative on 6th and 8th of June. Subsequently, following 2 days, he saw us in the clinic. His visual acuity was 0.6, 0.9 in the right eye, 0.7 not improving in the left eye. And we could see a vitreous hemorrhage, a small thin subhyaloid hemorrhage in the left eye, and the diabetic macular edema. Now, the question was, I asked him repeatedly whether he was diabetic previously. He said, no, he wasn't diabetic previously. He only got to know while he was admitted in the hospital for COVID reasons. Here you can see a neovascularization on an angiogram in both eyes. And you could also see there was a macular edema. So here we decided to inject him with the intravitreal injection like any other, diabetic macular edema with a proliferation. You would initially initiate the intravitreal injection of anti-VEGF, whether it is ranibizumab or aflibercept, followed by a pan-retinal photocoagulation. That's what we did. And he comes back. The next month, July, his vision is improving. You could see, PRP marks, and then the thinning of the subhyaloid hemorrhage. He received the second injection of anti-VEGF, and is further improving. And he received the third injection of ranibizumab in August, and he was doing extremely good. And then he was lost to follow-up for a couple of months. When he came back, again, he had I could see there is peripheral ischemic retina, which has not been, lasered. So I did the additional supplemental PRP. And then he had a macular edema. He received the 5th injection of intravitreal anti-VEGF. And he is stable since then. The second case is about the 43-year-old seen recently. This is in the 3rd wave of COVID. He complains of sudden loss of vision in the left eye, and he's diabetic for the last 1 to 2 years. He's hypertensive. He had a ischemic heart disease, and he was COVID positive 20 days back, and he became negative, during which he noticed the sudden loss of vision. He came to our clinic. He was in fact referred to us for the further management. You could see leaking of microorganisms, hard exudate in the right eye, and few probably neovascularization in the of the retina in the right eye. Whereas in the left eye, you could see a large subhyaloid pre-macular hemorrhage covering the entire posterior pole and also on the nasal retina. He underwent the angiogram. Again, it's a straightforward diagnosis of high-risk proliferative diabetic retinopathy. So we initiated the PRP for him. And obviously, the subhyaloid hemorrhage wouldn't have, absorbed because it was quite thick. So we decided to do a vitrectomy. He underwent a vitrectomy this last Monday. And this is the picture of day 1 post-op. He underwent paspalline vitrectomy, membrane dissection, endolaser under local anesthesia. His vision is 0.2 on the day 1. And you could see very nicely done PRP. The next is a 35-year-old. He's a gym instructor. He presented on February 2021. He was complaining of blurring of vision. Obviously, being a gym instructor and 35-year-old, he was healthy, but he gives a history of second COVID vaccination or Sinopharm on 17th of February 2021. His visual acuity was 0.31 in the right eye, 0.4, 0.1 in the left eye. We saw he was, it was an image of impending CRVO in the right eye with dilated tortuous retinal blood vessels, retinal hemorrhages, dot plot hemorrhages in all the quadrants. We also did the OCT, which showed a foveal contour maintained. So we said probably is about to develop a complete full-blown CRVO in the right eye. We explained him to have a complete evaluation with the internist. He underwent complete hematological evaluation. He came back after, you could see a OCTA. The foveal avascular zone was intact, both superficial and the deep plexus. He came back after a month with the counting fingers close to face in the right eye. So we saw the retina. It was significantly dilated tortuous retinal vessels, disc hemorrhages, retinal hemorrhages in all the quadrants, a significant macular edema, suggesting a conversion of a non-ischemic to a ischemic central retinal vein occlusion in about 3 to 4 weeks. So this is where we decided, we said this is the OCTA, which shows obviously it is not they imaged well because of the significant macular edema. He received the first intravitreal injection of aflibercept in the month of March. He came back the second month, which is in April. The macular edema is significantly reduced, though you could see cotton wool patches and absorbing retinal hemorrhages in all the quadrants. And subsequently, he underwent a third intravitreal injection of aflibercept. His foveal contour is maintained. His vision was 0.9 parts in the right eye. Left eye was good. And again, he received the fourth injection. Now, it's very interesting that in Abu Dhabi, after 6 months of a Sinopharm injection, we were asked, it was mandated to take a COVID vaccination again. So he took this time a first Pfizer vaccine and again a second Pfizer vaccine on September 2021. And he comes back again with a drop in vision in August. You can see a macular edema developing, and I could do an angiogram and see a lot of capillary dropouts in the periphery with again a lot of retinal hemorrhages. We decided to do a PRP and go in for an intravitreal anti-VEGF. This was in the month of October, and since then he's been stable. And the last case I'd like to show is
Doctor, if you allow me, okay,
yes,
we already finished with the cases.
Yeah. So
if
the
you can
last
have only
again a
comments
supratemporal branch retinal vein occlusion following Sinopharm vaccination, and he was treated again with anti-VEGF. He did well. Now my question is, now there is a lot of literature or publications in the recent past to say, I'll go to the next. This gentleman did well. His vision is 20/20. So what is the reason for developing vascular occlusion? It's a combined vasculitis and resistant to the venous blood flow in the center and causes a central vein occlusion. A SARS infection or the associated secondary effects such as cytokine storm or a thromboembotic tendencies. It is also thought that it might cause a disseminated intravascular coagulation, like what we have seen in other organs as well. Pathologic examination, which was done by Ackerman et al., showed it could be a thrombotic or a necrotic tissue, shows the evidence of a much higher amount of microvascular injury and a microthromboemboli. Diabetic microvasculature already has a compromised circulation and a high tendency for occlusion. This makes diabetic retinopathy patients more prone to occlusion when microthrombosis and microvascular injury happens as a result of COVID-19. And same thing can be applied to a COVID vaccination. That is why it is called inflammatory thrombosis with immune endothelitis, ITIE.
Thank you very much, Dr.
Madaprao. These are my references.
Presentation, and thank you. We can move to the next speaker. If there is any question or comment, it will be at the end because we're already over the time. Sorry for that. My pleasure now to introduce Dr. Alfredo Adan. He's a Director Institute of Ophthalmology Hospital Clinic of Barcelona, Spain, full professor, University of Barcelona. And his topic will be also, he's going to present for us a mystery case. Dr. Alfredo. Dr. Alfredo, you are there? He is here.
I don't think he's on the panelists, Mohammed.
No, he was there.
Okay.
Well, he was there. I don't know. Okay. Can you move to the next and check, please? Okay. Can we move, please, to the next speaker? So now is Dr. Ahmed Al-Barqi. He's an MD of RCS Ophthalmology, lecturer of ophthalmology at Penha University, Egypt, veterinary consultant at SKMC Abu Dhabi. And he will present a case of mystery of case, please.
Okay, thank you, Fran, but I cannot share my screen. They're telling me the other participant is sharing. So
there is no one is sharing now.
now it's okay. Yeah, now it's okay.
Yeah.
Okay, thank you, Dr. Muhammad, for the nice invitation, and it's a pleasure to be here with this eminent speaker. Just for the next time, I go back to direct to my case presentation. This is a female, 31 years old, diagnosed with retinitis pigmentosa with genotype a pathology variant of CRP1 gene. This is the genetic report came. She complained decreased vision. This is an old, normal complaint. The new complaint when she came to the clinic, she has just noticed a recent flash of light in both eyes. So in examination, the visual acuity went 20/100, good vision, but for sure very constricted visual field. Other thing is normal, and the fundus shows the clinical picture of retinitis pigmentosa. But what thing here we look at the previous inferior temporal at the periphery, you can find this exudation there in the left eye, and the same exactly in the right eye. So definitely we go for Fluorescein Angiography to know how this exudation came from. And if you look at the left eye, you can see there is some look at the early phase of telangiectatic vessel there, abnormal telangiectasia in the inferior temporal quadrant, and with going to the scene, it starts to leak. And there's the same picture in the right eye, inferior temporal quadrant, telangiectatic vessels there, and the leaking with late phases. So diagnosis is they have a case like that with with this kind of lesion peripherally.
Can we ask Dr. Ahmed and stop you 1 minute and ask our collegiate what they are thinking? Dr. Majdi Musa, what do you think we are facing?
It's a coats-like presentation with retinitis pigmentosa. It is in the literature, but it's bilateral. It's very unusual. Should be unilateral, but bilaterality is there. So it's going.
Can it be sickle cell?
No, I don't think so.
Okay, Dr. Fahad. So let us just very fast, Fahad.
Yeah, I agree with Professor Musa. This is a coats-like phenomenon, which is expected in somebody.
Okay, if there is no other differential than what is mentioned, is there any suggestion from any other rather than what they are already said? Okay, Dr. Ahmed, go ahead.
Yeah, so the diagnosis, I agree with Dr. Magdi, and this is what we call it this lecture. It's coat-like exudative retinopathy, senior retinitis pigmentosa. And I go for the literature, and I want to share you for the sake of time the latest publication about this one. It was in January 2021 in the Retina of Ophthalmology Retina, and they described this lecture and they give some other some characteristics. This is from the paper itself. So you can see it is almost the same that I've seen in my case. And also the fluorescein is there, leaking inferior temporal. So what they looked some criteria about this disease entity. They found that it can present in up to 5% of all our retinal pigmentosa patients. Retinal pigmentosa, it's this same we can use only if the patient has our retinal pigmentosa together with this exudation, and it can present at any time, but most commonly developed during the clinical course of vision, long-standing PR retinitis pigmentosa. And how do you see it from the coated disease or the regular coated disease? Exudative pathology usually happen only with retinitis pigmentosa. Restricted to the inferior temporal retina, can affect both eyes, and this is the new thing. It can find in both eyes, and definitely does not male 6 bias. Usually coat disease affects male only, but in this disease entity can do in both disease. And the value of this actually, or the importance of this, because if you have retinitis pigmentosa, we don't want to risk the patient if we miss such kind of disease, because the patient already have poor vision, and if you the risk of visual loss will be more if this oxidative retinopathy does not diagnosed and not treated. So as you know, the patient already has poor vision. So the recommendation from this paper is that you have to keep eye on this patient and look at the temporal retina, especially inferior part, to observe for any development of this vascular telangiectasia or aneurysmal dilatation or exudative retinal detachment. So going back to my case, so the plan. So do you observe or you try to laser or anti-VEGF or steroid or cryotherapy, which is the most common treatment modality for coat disease? So if anyone,
what you suggest, Madhav?
What can you suggest?
I think if there was no macular involvement, it was just an exudative in the periphery, or rather observe.
Observe. Okay.
Any other opinion?
Yes, Did you do OCT, Dr. Ahmed? You didn't, did you?
Yeah, I did OCT, sorry, but it's no edema. There is no edema.
There is no. My opinion, observation is sometimes fatal in these cases because we all know that this vitreoretinopathy might suddenly reach the macula. So we should not wait for that. Why don't we do laser? Laser for the periphery will not harm anything. We already lost their peripheral vision because it's a retinitis pigmentosa. So if we kill the new vessels by extensive laser photocoagulation to these areas, I think we can prevent prevent further complication. This is my opinion.
Any other opinion? Any other different opinion?
Yeah, I agree. Doing something instead of observation, because they usually keep exudating. They usually can get some ischemic areas as well. Some of them develop traction on the areas of exudation. And sometimes you cannot get away with cryo. You have to, with laser, you have to go on with cryo and even some surgery. I'm more for the start with laser and control.
Laser, okay. So no other
opinion?
No, just to kind of support my two colleagues. So I would always go for laser. I wouldn't watch these personally because they can rapidly escalate. And I'd only consider anti-VEGF if there's macular edema or there's a significant amount of retinal exudation.
Dr. Fahad, I think your voice is very far, Dr. Dr. Fahad.
I apologize. Sorry.
Can you hold the mic near to?
Of course. Sorry about that.
Go for laser, right?
No, we can understand what he's saying. Okay, let's go. If laser. There is any different opinion than what they are already said, okay, continue, Ahmed.
Okay, so I tried laser for the patient, but I was surprised that there is no good reaction. I cannot reach good reaction at all because the retina was elevated, and I tried very high power, so no, it's not work. So I go for intravitreal anti-VEGF. I give the patient 3 months injection of ranibizumab. I go to the literature. There is no preferable anti-VEGF, and there is no protocol also. It's not like the DME or.
Okay, Ahmed, why you give anti-VEGF here?
Because this is the second option, because I don't want to go for steroid because there is no macular edema, and also this young lady, you cannot expect cataract or high IOP or something like it's a phakic. So I start with anti-VEGF since the laser does not work good in my hand. I go for anti-VEGF. I give 3 months injection, but again, when I check her later or 1 month later, there is no change. So what is the next step now? And this is my next question to the panel.
Because we are behind the time, Ahmed.
Okay.
Dr. Majdi, are you agreed to go for intravitreal injection or you will do cryo?
Yes, if there is marked elevation of the retina, anti-VEGF might do the job. I mean, might decrease the leakage because this is a vitreoretinopathy. This is leaking vessels. But I don't give 3 injections. I give once and check because 3 injections sometimes is not the clue. It is not like in the literature. It's not an AMD or diabetic. It's once and you see the. But again, Ahmed, if you need my opinion, do laser photocoagulation surrounding the lesion if you cannot hit the lesion itself, and then later on you might get a chance to laser the telangiectatic vessels, but surround it so it will not reach or it will not leak into the macula. But the only thing.
What about cryo?
Cryo, yes.
Support cryo?
I don't like cryo. I don't like cryo at all in these cases. It will, but it will have severe inflammation, and you already had retinitis pigmentosa. And if this patient had the drop of vision, you will be blamed for that.
Very fragile, you know. Yeah, very fragile. Yes. You have to take care of it.
I hate cryo nowadays, but not in retinitis pigmentosa. Also, I don't think it will help much.
Thank you very much, Dr. Ahmed and Dr. Mahdi all. So we can move to the next speaker, please. So now is Dr. Fahad Kohel. He's a consultant ophthalmic surgeon, medical retina and uveitis specialist, Royal Hampshire Hospital, UK. And he will give a case of mystery. Please, Dr. Fahad, share your screen.
Thank you, Mohammed. So guys, this isn't a difficult case, but we welcome your thoughts. So it's a case that I saw during my residency. So I was a trainee at the time. It's a 19-year-old female with an acute lymphoblastic leukemia. She'd received an allogenic bone marrow transplant in September 2006. And post-transplant, she developed a CMV reactivation with a CMV PCR count of 230,000 copies per mil. She was commenced on ganciclovir, switched to cidofovir, and she had the other complaints she had was oral thrush and was on itraconazole. She presented to clinic, a couple of months after the bone marrow transplant complaining of blurred vision, headache, with no floaters. Vision was 6.9 on the right, 6.6 on the left. Normal color vision, no afferent papillary defect. There was no anterior uveitis, no vitritis, normal intraocular pressure. This is a color fundus photograph, which showed multiple cotton wool spots in both eyes. Now, believe it or not, I did my fellowship in 2008, 2007, 2008, 2009. So at that time, OCT wasn't easily available. So I don't have any OCT scans. But basically, the fundoscopy revealed numerous peripapillary cotton wool spots, retinal hemorrhages with no mid-peripheral or peripheral lesions. So I'd just like to ask the panel, what is the likely diagnosis and how would you investigate further? So I'll stop share at that point.
Okay, now
people's
if you
thoughts
can
are.
start, is there Dr. Adan is available because he have a problem with internet. So I can go now with Patricio first. What do you think, Patricio?
I would start seeing how many PCR copies the patient has in circulating blood. And then once you get the confirmation that the patient has systemic cytomegalovirus, you can go ahead directly. You don't need more than that. Of course, if it's not in your hands to do the investigation for the CD counts and all these things, but once you have the confirmation with PCR, you can start treating the patient. If it is unilateral with injections, even bilateral with intraocular injections, but I'm sure that the patient was carefully followed and they started on systemic treatment for this patient.
So the patient was already on systemic ganciclovir. So she developed these cotton wool spots subsequently. But I agree, CMV retinitis is one thing you need to consider. Any other diagnoses to think about?
Mets, it could be a metastasis. Leukemia.
Or HIV maybe.
And then any investigations, if you were going to do an ocular investigation, what would be your investigation of choice?
Fluorescein. Any other suggestions?
Vitreous sample.
Vitreous tap.
Yeah, thank you. I'll share the screen again.
You can continue the same. You don't need to stop share.
Yes.
No, yeah, sorry. No, what it is, because I'm on the phone, I can never see everybody at the same time.
No, it's okay.
Can you see my slide?
Okay.
Can you see my slide?
Yes, please.
Yes.
Yeah.
So at the time, we did an AC tap, which looking for viral PCR, which returned completely negative. I think her CD4 count was good, and neuroimaging and CSF analysis, and her LP opening pressure was normal. And so actually, we diagnosed her with a posterior segment graft versus host disease because she actually had received an allogenic graft. So we didn't do a fluorescein or any additional investigations like that. So just very, very quickly, what is ocular Gvhd? Hematopoietic stem cell transplantation is established treatment for treating blood cancer. Transplanted stem cells are obtained from the donor bone marrow, and these stem cells may be autologous or allogenic from an HLA-matched donor. And before transplantation, you get high-dose chemotherapy, which eradicates the host marrow stem cell population. And graft versus host disease is one of the major causes of morbidity and mortality in these group of patients, occurring in about 25-70% of patients. It affects the skin, mouth, liver, and of course, including the eye. GVD occurs because immunologically competent donor cells are stimulated antigenically by the host antigens, and the host is incapable of mounting an effective immune response against the graft. And that disparity in the histocompatibility between the donor and the recipient is the strongest predictor for graft versus host disease. And it can present in an acute form or a chronic form, anything between 100 days after the bone marrow transplant. And the prophylactic measures could include deactivating or eliminating donor T cells, or using immunosuppression like cyclosporin A and methotrexate. The ocular surface manifestations are the predominant manifestation of ocular graft versus host. So you get aqueous tear deficiency, cicatricial conjunctivitis, and as we know, dry eye is the most common kind of side effect, or the most common manifestation, of ocular Gvhd. And it's because you get really good, good going inflammation of the lacrimal glands, and that kind of induces your dry eye. And this is a 13-year-old boy who had undergone bone marrow transplantation for an acute lymphocytic leukemia, and the CT scan shows marked preseptal soft tissue swelling 21 days after the bone marrow transplant. So that's the main manifestation. However, surprisingly, they can get posterior segment manifestations. Just to remind everybody, if you have got a patient with ocular surface Gvhd, preservative-free artificial tears are the mainstay of therapy. But if they have refractory dry eye, sometimes I find in my care, autologous serum eye drops may help, or I might sometimes give them a bit of steroid, followed by long-term topical cyclosporin, has done a great deal in reducing the frequency of lubricants and controlling their symptoms. As for posterior segment complications, they're rare. There's few cases reports in the literature, and the onset of symptoms can range from 1 month to many months, up to 10 months, after the allogeneic ENT. And the relative common complications include microvascular retinopathy with cotton wool spots, intraretinal hemorrhages, and we believe it's secondary either to the graft versus host or secondary to the underlying disease process or the chemotherapeutic agents. And in one series of 397 patients that were observed after undergoing bone marrow transplant, around 13% developed posterior segment complications, including 17 with cotton wool spots. And obviously, don't forget, central serous retinopathy can be an uncommon complication in this group of patients, and there have been the odd reports of posterior scleritis in association with graft versus host disease. So I'd like to thank you for that.
Thank you very much, Fahad, for this excellent case presentation. If there is any comments, we have only less than 1 minute. Dr. Majdi or Dr. Ahmed Khashab, Ahmed Barqi, Madaf, anyone want to comment, or we can go further in the next speaker? I think Fahad covered it very nicely and explained it. So we can go to the next speaker, please. So now, Patricio, you are still in the airport, Patricio, or you already in the airplane?
No, in the airport yet.
Okay, good. So I hope that we will not listen for a lot of noise behind you. But anyway,
No
Dr. Patricio Lorenzo, he's an FRCS, also consultant ophthalmologist, Corneal Cataract and LASIK Eye Surgery Hospital in Dubai. Yes, please.
Can you see my screen now?
Yes.
Yes.
So greetings from Madrid, Spain. Thank you to Dr. Alamri for his kind invitation, having me today, sharing this great symposium with all my dear friends. So this is a normal patient. This is a 67-year-old patient who they sent it to me because the patient was complaining of vision loss, but in the end, the only thing he had was corticonuclear cataracts. So I refer the patient to my colleagues, the cataract surgeons, and then these are the OCTs before the surgery. That is in the left eye, a little bit of epiretinal membrane, a pucker, but nothing very special. So I refer the patient for surgery. He has an uneventful cataract surgery in both eyes, 1 week apart. And then after 1 month's review, the patient was complaining that the vision was getting worse, despite having had a very good vision after the surgery. At this time, vision was 0.7 and 0.6. I didn't know anything about the patient. It was no longer my patient. And the OCTs were not so good this time. So you can see something like fluid and the retinal and neurosensorial in the right and a little bit of neurosensorial in the left. So what do you think we are dealing with here?
Could it be
Okay,
Irving Gas?
Dr. Ahmed Khashab, please, if you have any comment.
I agree. Could be Irving Guy's syndrome, definitely.
Yeah.
Okay, any other opinion? Dr. Majdi, Dr. Madaf?
The contour of OCTs, which is highlighted in the with the fovea, suggests, it's a cystoid macular edema post-cataract surgery, likely to be Irving gas. So we need to do an angiogram to show a disc leakage.
But you know, the cataract surgeons, they don't do angiograms, my friend. Come on, Dr. Rao.
Yes,
so
they don't.
Who is next to
They don't.
cataract surgery.
You will do, Patricio.
And yeah, but listen, usually you don't do anything for patients coming with Irving gas 1 month after surgery, which is the usual time of coming with Irving gas. And they did what they usually do, that it is to put the patient back on steroids and non-steroidal anti-inflammatory medication, and to ask the patient to come back in 2 weeks. I have to say that, yeah, it can be an Irvine gas, but you don't get Irvine gas in a, let's say, normal patient so often in both eyes at the same time.
Yes, we do agree on that.
Yeah.
So 2 weeks
It could
later,
be another thing's reason.
that's a mystery case. It's a mystery.
Could be a burn.
Uveitis. Let's see the scenario,
We'll see.
Dr. Patricia.
Let's go on. Let's go on. So the 2 weeks later, the visual acuity was 0.6 and 0.6 partially, and they called me this time. So I had a look at the patient. I always look at the vitreous, and I found vitreous cells in both eyes that most cases of Irvine gas do not have. The OCTs were, they don't need any comment, definitely worse this time. So what do you think now?
I just wonder when this patient...
it is not that mystery. I mean, it's bilateral cystoid edema with sensory detachment. It could be uveitis because he has cells in the vitreous. Probably, if he has cells in the AC, it could be uveitis, and uveitis can be reflected by cystoid macular edema. Let's see what you can make from there.
Okay. So,
Patricio, did they miss when they assessed the patient preoperatively?
I cannot listen. I cannot hear you.
Sorry, who's
sorry,
talking?
apologies. It's Fahad. When they did when they assessed the patient preoperatively, did they identify any low-grade anterior chamber inflammation, any vitritis, any preoperative cystoid macular edema? Nothing.
Nothing. I saw the patient myself. There was nothing. That's why I sent the patient for cataract surgery. I look, the first thing I look at any one of my patients is if they have vitreous cells, just in case. 100% of the case. Of course, dilated examination, OCT, and everything, completely normal. The patient was not taking any medication, not using any drops. The typical normal 67 years old patient, very fit person. So this is a differential diagnosis. The first thing, as you all rightly thought, is Irvine gas. It could be a diabetic CME, but our patient was not diabetic. It could be systemic or local inflammation or infection. It could be a previous vein obstruction, but didn't have any signs. The patient could be using any of these medications that can produce macular edema, but he was not using, or others. So what I did was to re-examine the patient. There was nothing new. I sent the patient to internal medicine for careful evaluation, and I put the patient on 60 milligrams prednisolone once a day, and I kept the topical non-steroidal medication. I asked the patient to come back in 2 weeks, and the patient didn't come back in 2 weeks, but fortunately came back in 3 weeks. And he kept the treatment during all these 3 weeks. Internal medicine did a good job, and they did, among many other things, they did a colonoscopy with biopsy, and they found that the patient had intestinal inflammatory bowel disease, concretely Crohn's disease. The visual acuity at this time was 0.7 and 0.6. The OCTs were getting better, and we started to taper the steroids. So 1 month later, the patient was on 20 milligrams of prednisolone. The OCTs were getting better. The vision was 0.9 and 0.7, and the prednisolone was reduced to 15 milligrams a day. No interretinal fluid, maybe a little bit of subretinal fluid at the foveola. But vision was very good. Patient was very happy. At the last visit, the visual acuity was kept 0.9, 0.7, no fluid, prednisolone reduced to 10 milligrams once a day, and we are there. So still, I don't know if the patient is going to flare up again. So in conclusion, when you see a bilateral CME after, you have to look for vitreous cells. It should be investigated. It could be something like a masquerade or for uveitis or systemic problems. You should review the patients frequently. Sometimes it takes a long time to recover. And of course, a careful follow-up is always advised. And thank you to you all.
Thank you very much. This very nice and mystery really case. Thank you, Patricia, for this case. So we discussed everything, I think. Is there anyone want to comment before we move? Yeah, Dr. Madaf, please.
Dr. Patricio, was it a sequential cataract surgery? That's one. Second, instead of oral prednisolone, probably I would have tried a posterior subtenon triamcinolone, long-acting steroid.
Yeah,
it would have taken.
That's an array of possibilities.
We would have avoided the side effects of oral steroids.
Don't forget that the subtenon injections can have systemic effects as well.
Mostly the local the cataract is removed, the other one is the glaucoma.
I agree. I mean, there is a variety, and I can't take that people can say, okay, I will put an Osurdix in every eye, fine. Or I will put orbital fluoresteroids, fine. Even some people, yeah, even some people can try to inject anti-VEGF. I wouldn't do it with cells in the vitreous, but I mean, you know that there is a wide variety.
Was it a sequential cataract surgery? Was it done within not much of a gap between?
Completely uneventful phacoemulsification with.
Was it done, say, on the third or the fourth day or a week later after the first surgery?
1 week apart.
So these kind of
you mean OCT? OCT no. OCT was done at the month.
The sequential cataract surgeries can lead on to a cystoid macular edema. There are literatures.
I think, in my opinion, we triggered inflammation in a not known Crohn's disease patient. I mean, the cataract actually surgery, it was the triggering motive for this.
Okay, we can move, dear colleagues, and we will have a time next after the end of the session. So, my dear friends, Dr. Ahmed Al-Khashab, he's an MD of RCS Glasgow, ophthalmology consultant, head of vitreoretinal unit, and medical director of Eye Consultant Center in Dubai Healthcare City, Dubai. And Ahmed for a mystery case.
Thanks a lot, Mohammed, for your presentation. It is always my pleasure and a great conference as usual.
Thank you, Ahmed.
Okay, so I have a couple of cases. I'll go very quickly with those. Actually, the first patient is a 42 years old male patient, Caucasian. He came complaining of sudden drop of vision in the right eye. The visual acuity was 20/50 in the right eye, 20/22 in the left. Intraocular pressure was normal, clear cornea and lens. He had no medical history, none of ophthalmic history. Family history, his mother just developed a choroidal neovascular membrane. She's 82 years old lady. This is the image at presentation. This is the colored and autofluorescence. And we can see a lesion, peripapillary, highly elevated subretinal. We can see the blood vessel crossing over. What do you think about that? If we can stop it here and ask Dr. Gvhd.
Well, I mean, from the color picture, there is a mass lesion, yes, but from my opinion, we need fluorescein angiography to judge it because we don't see 3D. But if you want my differential diagnosis, it could be a CNV, it could be a inflammatory lesion, because I can see surrounding the lesion, there's elevation superior to the lesion, which could be fluid, probably.
Okay. Yeah, so I'll go quickly. When he was referred to me, he was suggested to have a tumor or a mass, and this was his diagnosis by the MRI that he did, and he was referred just for a second opinion and just delineating the mass and so on. This is the OCT. Initially, we can see the fluid extending near to the fovea. This is the fluorescein angiography, no much leakage and late leakage here. We can see it on this frame. And this was the B scan. It's an elevated, a bit of elevated lesion. This is the OCT angiography. Sorry about the quality, but I think maybe I have another one. Yeah, we can see here, this is the lesion. And I agree with Dr. Gvhd. I diagnosed him as choroidal neovascular membrane, and I did not think of any tumor at time. And this is another image after I started him on anti-VEGF injections. And the patient was given 3 successive injections. And after this, this was totally regressed. And I think this is the last OCT 1 year apart from the first 3 injections. This is totally stable. He usually comes for follow-up every 2 months, and there is no activity whatsoever. Although the age does not fit the choroidal neovascular membrane and or the age-related macular degeneration, but we have multiple causes of CNV. Not just age-related myopic, although this patient is not. It does not fit in any category of those, but idiopathic choroidal neovascular membrane is seen.
Is it a pachychoroid, Dr.
Any
Ahmed?
fundus?
Is it a pachychoroid? Could be a pachychoroid?
Yeah, it could be a pachychoroid.
Could it be post-inflammatory, doctor?
It can, but I have not seen any signs of inflammation. There is no cells whatsoever in the vitreous.
Adjacent to the scar?
No, none.
Ahmed, I think the OCT picture you showed us when the cut section cut at this lesion, yeah. This lesion, it's similar for me. I don't know. This is, subretinal hypersensitive material, the shrimp material, which is commonly seen in CNV, non-active. So for me, it looks like that because it's not leaking on fluorescein angiography, it's not activity, and the fluid is far away from
the injection. But before the injection, there was definitely fluid, and there was
But for me, it's like such kind of shrimp or subretinal hyperreflective material, because that could be. I mean, we are thinking the same way. It's a CNV, not inflammation or other tumor or something. So we are the same loop, which is CNV.
Yeah. I've seen a lot of cases of idiopathic choroidal neovascular membrane. Most of them are females. And I think they are hormonal, and I have seen relapse on hormonal changes whenever they got pregnant or something like this. It flares up once again. But for this patient, fortunately, he responded well and he's stable all through. I will go briefly to this female patient. She came also complaining of drop of vision. I think in the right eye. I'm sorry about the vision in the left. She had a history of glaucoma for a long time. She was following up with me for a long time, since 2015. She had hypertension and DME controlled. There is no diabetic retinopathy whatsoever. Cataract surgery was done 7 years ago in another country, in Egypt, and she was on Ganfort for glaucoma. She was controlled IOP. She had a family history of loss of vision for her mother. This is the left eye. She's high myopic, but definitely now she's corrected after the cataract surgery. I just showed the image before for the left eye. So this is the image of the left eye. When she came complaining of drop of vision in the right eye, this is the image. So we can see that there is foveous cases, and there is some cystic spaces and subretinal fluid here. I cannot know whether you can see the mark or not. And this is the OCT angiography on presentation. I cannot see any choroidal neovascular membrane. I was not sure that there is anything. It can be a myopic CNV, but I haven't seen that. So I told her we will keep a follow-up, especially because this was the image before. This was 2018. This is the image. There was a foveous cases already in this patient for the right eye. This is 2015 on the right side, and 2018 on the left side. This was the image. So there is already a foveous cases from the start. Definitely, this is a totally different image from now, from this presentation. And that's why the patient is came complaining of drop of vision. So in such condition, what would you do? Would you do any other investigation other than the OCT angiography?
Yes, I would do fluorescein angiography to differentiate between leakage and schisis, because in the fluorescein, if there is no leakage, there is no insult to the vascular element, so it might be a progressive myopic retinoschisis.
Okay, so I do not have the fluorescein angiography, although it was done outside, and she actually took another opinion back in Egypt, and she was injected there for 3 successive injections. She came back to me with this image. So there was no improvement whatsoever, and the diagnosis was choroidal neovascular membrane. And she's asking me what to do next. This is the OCT again. So
sorry, I remember Carlos Mateo had a series of macular schisis in myopic patients that he operated with a special scleral explant with great success.
Yeah. But the vision here is 20/50. I would not consider any surgery for this patient at that stage. Yes, she's complaining, but still. And one more thing, she was using Gvhd. So I thought maybe the prostaglandin can play a role in increasing the Phobia schisis. So I stopped the prostaglandin for a while. I shifted to another drop. She was not happy. She did not, and the pressure started to rise up to 24, and she's glucomatous. So I was not happy with the result. No improvement and nothing. So she told me,
observation, Ahmed, I think is. I think it's observation because there is nothing is changed.
Yeah, that's why I advised her from the start for observation. But
okay, is there any other opinion? Because we're already behind the times and we went to conclude our session.
Let me move on. So actually, she did not improve. The vision was dropping to 20/70. So I thought, let's give her a chance for anti-VEGF with another type, Eylea in this case. And this was after 1 month, no much of improvement. I thought maybe I was doing wrong. After 2 months, no change whatsoever. After 3 months, I felt that there is an improvement, and the vision improved back to 20/50. And this is the OCT angiography. No definitive lesion of choroidal neovascular membrane still. And she started to improve. She's feeling happy. Now she's better after 4th injection. You can see the improvement. And now suddenly all the schisis are gone. This is after 4 injections. This is after the 5th injection. And it's totally gone. Even the Phobia schisis itself is totally gone. And this is the last image for her, the vision back to 20/20. It is even better than the left eye. It's quite amazing, quite unusual for me. That's why I wanted to share it with you and to see if you have any different opinion.
Thank you very much, Ahmed. Very nice and very interesting cases as usual. Only less than 1 minute. If there is one, have to comment, Dr. Majdi or Dr.
Yes,
Fahad.
I need to make a comment. I don't think
fast,
the injection did the job. I don't think so. Probably the injection made the vitreous more and more liquefied, separated the posterior hyaloid, the schisis is gone. Because I have a case like this, before and after surgery, there is complete resolution of retinal schisis after phacoemulsification. So sometimes playing with the vitreous, like complete vitreous separation, PVD, or liquefaction of the vitreous with time after the injections, then she had regressed retinal schisis. But again, I don't think the injection did the job, because she has no CNV, she has no diabetic macular edema. This is a definite retinal schisis. And the natural course sometimes takes a very long time, or injection might make a mechanical separation of the posterior hyaloid. This is my opinion.
Okay, any different opinion before we close?
My only thought is whether the anti-VEGF has a direct anti-permeability effect. So possibly because she's got myopic tractional maculopathy, and whether the anti-VEGF stabilizes the blood vessels slightly to allow the RPE to dry the macula better. But the PVD is also a good thought. You know, whether the
so it's the same as Dr. Majdi. Okay, any different opinion, please?
No, because Muhammad, I think myopic CNV, one of the most responsive type of CNV for anti-VEGF. So I think I go with the flow. This is most commonly not CNV. It's like, as the other colleagues said, it's prophylaxis. Yeah, I agree with that.
Okay. Anyway, thank you very much. Thanks, Ahmed. You are all the time bringing a difficult cases as usual. And at the end, we don't know what to do. Thank you very much, Ahmed. Thank you for all.
Is that good or bad? Is that good or bad?
Ahmed Al-Khashab.
Ahmed Khashab, is that good for him or bad for him?
Good for him for sure.
I don't know. I don't know. You will answer by phone, Dr. Majdi.
Thank you.
Thank you, Madaf. Thank you, Fahd Marfi. And we apologize for Dr. Adan. He couldn't join us because of the internet from his side. So it was a very interesting and nice session as usual. I was very happy and proud to be between an eminence and friends and colleagues, brothers in this session. At the end, just I want to share with, if you share with me the screen, please. Management, if you share the, okay. No, share the, please, the screen, please, for the myome, if you don't mind. I told you.
Advertising.
For the next year?
Advertising, please, yes.
For the next
October.
year?
Okay. Just, I would like to invite you all, dear colleagues, for myome. It will be physical, or you can in person in Dubai, 14 to 16. No, not virtual. Physical. Save the date. See you in Dubai. Thank you very much.
already في دبي يا احمد يا بكري يا برقي يعني انت فيرتشوال من لايف
conclude these sessions. I think there will be a session for a company symposium industrial, and there is Dr. is waiting for us to conclude. Thank you very much and goodbye.
Thank you.
And the floor is for Francisco.
Thank you.
Thank you. Bye. Bye. Bye.
Thank you.
Bye. Bye.
Bye. Bye.